Cortical mastoidectomy. Cortical mastoidectomy is exentration of all accessible air cells of the mastoid bone. Exentration of all accessible air cells of the mastoid bone. Indications of coalescent mastoiditis. Coalescent mastoiditis is a preliminary step in the following procedures like coalescent mastoiditis, tubotympanic disease with discharging ear, tubotympanic TTD with discharging ear, in cochlear implant procedure, cochlear implant, TTD with discharging ear, cochlear implants, endolymphatic sac decompression, facial recess approach, translabyrinthine approach to internal auditory meatus, translabyrinthine approach to internal auditory meatus, translabyrinthine approach to internal auditory meatus, infratemporal fossa type A, infratemporal fossa type A approach, infratemporal fossa type A approach. So coalescent mastoiditis, preliminary step in tubotympanic disease with discharging ear, TT disease with discharging ear, CI, cochlear implants, endolymphatic sac decompression, facial recess approach, translabyrinthine approach to internal auditory meatus, infratemporal fossa type A approach. So procedure, mastoid air cells are exentrated using various size cutting and diamond burrs. First, the important landmarks of the lateral surface of the bone like spine of Henle, mastoid tip and linea temporalis. Spine of Henle, mastoid tip and linea temporalis are identified. Spine of Henle, mastoid tip and linea temporalis are identified. Spine of Henle, mastoid tip and linea temporalis are identified. Spine of Henle is a variable landmark that lies posterior superior to the external auditory meatus. You better avoid using as a sole landmark. Spine of Henle is a variable landmark posterior superior to the external auditory meatus. Better avoid this as a sole landmark. Mastoid tip is identified inferiorly. Mastoid tip is identified inferiorly. Mastoid tip is inferiorly. And linea temporalis is a ridge of bone extending from superior border of zygomatic arch posteriorly onto the mastoid cortex. Linea temporalis is a ridge of bone from superior border of zygomatic arch posteriorly onto the mastoid cortex. Posteriorly onto the mastoid cortex. It is the inferior limit of the temporalis muscle. Inferior limit of the temporalis muscle. Linea temporalis is the inferior limit of the temporalis muscle. And medial cranial fossa dural plate. And middle cranial fossa dural plate. Middle cranial fossa dural plate. So linea temporalis, spine of Henle, mastoid tip. So linea temporalis, ridge of bone extending from superior border of the zygomatic arch posteriorly onto the mastoid cortex. Superior border of zygomatic arch posteriorly onto the mastoid cortex. Inferior limit of temporalis muscle. And middle cranial fossa dural plate. Using a large cutting burrs, boundaries of large cutting burr, boundaries of McEwen's triangle are marked by 3 cuts. Landmark for opening the antrum, which is 1.25 to 2 cm deep to the lateral surface of the mastoid bone. Landmark for opening the antrum, which is 1.25 to 2 cm deep to the lateral surface of the mastoid bone. First cut is marked along the linea temporalis. First cut along the linea temporalis, that is a ridge of bone extending from superior border of zygomatic arch posteriorly onto the mastoid cortex. Ridge of bone extending from superior border of zygomatic arch posteriorly onto the mastoid cortex. First cut is along the linea temporalis. Second cut is posterior and parallel to the posterior meatal wall towards the mastoid tip. Posterior and parallel to the posterior meatal wall. 3 P's. Posterior and parallel to the posterior meatal wall towards the tip of the mastoid. Posterior and parallel to the posterior meatal wall, tip of the mastoid. Third cut is perpendicular to the first cut and tangential to the second cut. Third cut is perpendicular to the first cut and tangential to the second cut. It roughly indicates the level of sigmoid sinus, thus creating a triangle of attack. These 3 are the consistent landmarks. Using a large and short shaft cutting burr, cortical bone of triangle is removed by continuous irrigation. Large and short shaft cutting burr, cortical bone of triangle is removed by continuous irrigation. Mastoid cortex is opened systematically with wide saucerization rounded edge delineating the tegmen plate superiorly by removing the peritegmen air cells. Peritegmen air cells. Posterior meatal wall anteriorly and sigmoid sinus posteriorly by exentrating the perisinus and retrosigmoid cells. Posteriorly by exentrating the perisinus and retrosigmoid air cells. In order to provide maximum visualization before entering the antrum. Perisinus and retrosigmoid air cells. Thus, kidney-shaped mastoid cavity is obtained. These structures like tegmen plate and sigmoid sinus are identified by change of color in the bone. Sigmoid sinus is bluish and tegmen plate is pinkish. And presence of bleeding in live surgery. So, linea temporalis, spine of Henle, mastoid tip are identified. Drilling started along the linea temporalis, first cut, second cut, and third cut. Third cut is perpendicular to first cut and tangential to the second cut. Second cut is posterior and parallel to the posterior meatal wall towards the mastoid tip. Next, triangle of attack is created, and saucerized mastoid cavity, peritegmen air cells, perisinus air cells, sinodural angle air cells, periantral air cells, mastoid tip cells. The antrum lies at the deepest portion of the junction of the first two cuts, or posterior superior to the spine of Henle. Antrum lies at the deepest portion of the junction of the first two cuts, and posterior superior to the spine of Henle. Posterior superior to the spine of Henle, in the angle between the root of zygoma and posterior meatal wall and delineated tegmen plate. Root of zygoma, posterior meatal wall, and delineated tegmen plate. To open the antrum using appropriate size burr tips, deeper portion of the bone in the angle between the posterior meatal wall and tegmen plate and root of zygoma is removed. To open the antrum using appropriate size burr tips, deeper portion of the bone in the angle between posterior meatal wall and tegmen plate and root of zygoma is removed. Do not dig a deep dark hole while exploring the antrum. Do not dig a deep dark hole while exploring the antrum. So mastoid antrum, dome of the lateral semicircular canal are identified. It is advisable to avoid entering the antrum in a constricted area, or else one may injure the lateral semicircular canal. Injury probabilities for lateral semicircular canal: facial nerve at the second genu, tegmen plate, and lateral sinus. Lateral semicircular canal, facial nerve at the second genu, tegmen plate, and lateral sinus. Lateral semicircular canal, facial nerve at the second genu, tegmen plate, and lateral sinus. Lateral semicircular canal, facial nerve at the second genu, tegmen plate, and lateral sinus. Lateral semicircular canal, facial nerve at the second genu, tegmen plate, and lateral sinus. Lateral semicircular canal, facial nerve at the second genu, tegmen plate, and lateral sinus. Once the antrum is opened, the dome of lateral semicircular canal is seen in the floor of the antrum. Dome of the lateral semicircular canal is seen in the floor of the antrum. Dome of the lateral semicircular canal is seen in the floor of the antrum. Dome of the lateral semicircular canal is seen in the floor of the antrum. Antrum is further widened by thinning the posterior meatal wall and removing the cells in the root of the zygoma. In the region of angle between middle cranial fossa plate and posterior superior meatal wall until the short process of incus is visible lateral to the canal. Until the SIP is visible. Antrum is opened. Dome of the lateral semicircular canal is seen in the floor of the antrum. Antrum is further widened by thinning the posterior meatal wall and removing the air cells. In the root of the zygoma. In the region of angle between middle cranial fossa plate and posterior superior meatal wall. Until a short incudal process SIP is visible lateral to the canal. Antrum is widened by thinning the posterior meatal wall and air cells removed in the root of the zygoma in the region of angle between middle cranial fossa plate and posterior superior meatal wall until the SIP is visible lateral to the semicircular canal. If lost on the way to antrum, especially in cases of high sclerotic mastoid, go high and forward so that the middle cranial fossa dural plate is identified. Go high and forward so that the middle cranial fossa dural plate is identified. Using the appropriate size cutting burr, drill the angle between the dural plate, canal wall, and root of zygoma. So, if lost in the way to antrum, in the cases of high sclerotic mastoid, go high and forward so that the middle cranial fossa dural plate is identified. Using the appropriate size cutting burr, drill the angle between dural plate, canal wall, and root of zygoma. Even in cases of low-lying dura and anteriorly placed sinus, go medially along the middle cranial fossa dural plate. Low-lying dura and anteriorly placed sinus, go medially along the middle cranial fossa dural plate. Go medially along the middle cranial fossa dural plate. In cases of low-lying dura and anteriorly placed sinus, go medially along the middle cranial fossa dural plate. This plate can be followed into the antrum without injuring the lateral semicircular canal or getting lost in locating the antrum. This plate can be followed without injuring the lateral semicircular canal and getting lost in the locating the antrum. So one is mastoid antrum, dome of the lateral semicircular canal and the floor of the antrum. Once the heavier bone is removed over the tegmen plate and sigmoid sinus, thinning is performed with a diamond burr and stop further drilling if the change in the sound of the burr is heard. Stop drilling if the change in the sound of a burr is heard. After the dural plate and sigmoid sinus is well delineated and blue lined, exentrate all the air cells in between them in posterior to anterior direction, from behind to forward, in posterior to anterior direction, including the sinodural angle air cells, retrofacial and perifacial air cells. Posterior fossa dural plate is delineated anteromedial to the sigmoid sinus, by exentrating the air cells over it. Posterior fossa dural plate is delineated anteromedial to the sigmoid sinus. Posterior fossa dural plate is delineated anteromedial to the sigmoid sinus. Posterior fossa dural plate is delineated anteromedial to the sigmoid sinus by exentrating the air cells over it. Posterior fossa dural plate is delineated anteromedial to the sigmoid sinus by exentrating the air cells over it. Cells in the sinodural angle are removed by removing the drill medial to lateral. Cells in the sinodural angle are removed by moving the drill medial to lateral in order to avoid causing trauma to semicircular canal. Semicircular canal trauma is avoided by medial to lateral. While removing the cells in the sinodural angle, care is taken not to open the sinodural plate. From medial to lateral you open. If the sinodural plate is penetrated, it results in extensive bleeding due to exposure of superior petrosal sinus, which runs all along the sinodural angle. So sinodural plate is penetrated, bleeding due to superior petrosal sinus, SPS, superior petrosal sinus, runs all along the sinodural angle. Posteriorly entering into transverse sinus. And anteriorly into the cavernous sinus. Posteriorly entering into the transverse sinus and anteriorly entering into the cavernous sinus at the petrous apex. Anteriorly entering into the cavernous sinus at the petrous apex. By removing the cells between horizontal canal and sinodural angle, that is, by removing the cells between lateral semicircular or horizontal semicircular canal and sinodural angle, we encounter the hardest bone in the body called as hard angle, which is a part of aortic capsule. Removing the cells between horizontal canal and sinodural angle, we encounter hardest bone of the body called hard angle. Removing the cells between horizontal canal, that is lateral semicircular canal, and sinodural angle. We encounter hardest bone, hard angle, part of aortic capsule. So retrolabyrinthine air cells, sinodural angle air cells, sigmoid sinus, sinodural angle, tegmen plate, antrum, tip cells. Tegmen plate, sigmoid sinus, retrosigmoid air cells. Next. Inferior to sigmoid sinus lies a large air cell containing the mastoid tip. Inferior to sigmoid sinus lies a large air cell containing the mastoid tip. Inferior to sigmoid sinus, a large air cell containing the mastoid tip. Laterally, there is no danger of entering any vital structures. So tip is cleared of air cells. Tip is cleared of air cells to gain better exposure to jugular bulb. The tip is cleared of air cells to gain better exposure to jugular bulb. Most inferior area of the mastoid tip bone is thinned by drilling medial and lateral tip cells. Medial and lateral tip cells to expose the digastric ridge. Most inferior of mastoid tip bone, most inferior area of mastoid tip bone is thinned by drilling medial and lateral tip cells. Medial and lateral tip cells to expose digastric ridge, which runs anterior to posterior and lateral to medial direction. Digastric ridge runs from anterior to posterior and lateral to medial direction, starting inferior to the sigmoid sinus and ending at the stylomastoid foramen. So digastric ridge is exposed by inferior area of the mastoid tip bone drilling. Inferior area of the mastoid tip bone is thinned by drilling medial and lateral tip cells to expose the digastric ridge, which runs anterior to posterior and lateral to medial direction, starting inferior to sigmoid sinus and ending at stylomastoid foramen. Inferior to sigmoid sinus and ending at stylomastoid foramen. Anterior end of the periosteum of digastric muscles form one of the landmarks for facial nerve. Anterior end of the periosteum of digastric muscle form one of the landmarks for facial nerve. So inferior to sigmoid sinus lies the large air cell containing mastoid tip. Laterally, there is no danger of entering any vital structures. Tip is cleared of air cells to gain better exposure to jugular bulb. Most inferior area of the mastoid tip is thinned by drilling medial and lateral tip cells to expose the digastric ridge. Digastric ridge runs anterior to posterior and lateral to medial, starting from the inferior to sigmoid sinus and ending at stylomastoid foramen. Anterior end of the periosteum of digastric muscle form one of the landmarks for facial nerve. Exentration of the mastoid air cells is performed in a systemic fashion from one identified structure to other. So sigmoid sinus, sinodural angle, periantral air cells, retrodigastric air cells. Removal of the lateral tip cells. Removal of the medial tip cells. Retrosigmoid area, digastric ridge. Sigmoid sinus, lateral semicircular canal, sinodural angle. Delineating the digastric ridge. Digastric tendon, digastric muscle and sigmoid sinus. Cortical mastoidectomy is complete once the posterior canal wall anteriorly is the posterior canal wall, superiorly is the tegmen tympani, sigmoid sinus is posteriorly sigmoid sinus, digastric ridge is inferiorly. So cortical mastoidectomy is complete once the posterior canal wall lying anteriorly, tegmen tympani lying superiorly, sigmoid sinus lying posteriorly, digastric ridge lying inferiorly, and lateral semicircular canal in the floor and shadow of incus well delineated and clearly visible. Lateral semicircular canal in the floor and shadow of the incus well delineated and clearly visible. In the end, cavity is polished using a diamond burr. Removal of the medial tip cells. Next, digastric tendon, sigmoid sinus, sinodural angle, tegmen plate, antrum, incus, and lateral semicircular canal. These are identified after cortical mastoidectomy. Corner septum, a highly pneumatized bone. Corner septum may be encountered. It is a non-pneumatized bone plate, lying deep to mastoid cortex, within the air cells of well-pneumatized temporal bone, representing the fusion of petrosquamous suture, PS, corner septum is petrosquamous suture, separating the superficial squamous cells and deeper petrosal cells. Corner septum is a non-pneumatized plate of bone lying deep to the mastoid cortex within the air cells of the pneumatized temporal bone, representing the fusion of petrosquamous suture, separating the superficial squamous and deep petrosal cells. It extends from temporomastoid suture line in the posterior canal wall and blends with peritegment and synodural angle cells. Temporomastoid suture line in the posterior canal wall, and blending with the peritegment synodural angle cells. Mistaken for hard bone of the labyrinth and horizontal semicircular canal. Extends from temporomastoid suture line in the posterior canal wall, blends with peritegment synodural angle cells. Temporomastoid suture in the posterior canal wall, blends with peritegment and synodural angle cells. PT and SD, synodural angle cells. This plate is penetrated in anterosuperior quadrant to enter the antrum. This plate is penetrated in the anterosuperior quadrant to enter the antrum. Anterosuperiorly, corner septum is penetrated. Anterosuperiorly. Antrum is identified as a large air-containing airspace and continues anteriorly with the tympanic cavity through the adductus ad antrum and posteriorly with the mastoid air cells. Medial wall is lateral and posterior semicircular canal. Roof is formed by tegmen antri. Medial wall is LP, lateral and posterior semicircular canals. Medial wall of the antrum is LP or HP. Horizontal and posterior semicircular. Medial wall is LP or HP. Roof is tegment TA. LP or HP is the medial wall. Lateral wall formed by squamous portion of the temporal bone. Lateral wall is squamous temporal bone. Floor is formed by dome of lateral semicircular canal. So medial wall is LP or HP, lateral or posterior semicircular canal. Roof by tegmen antri. Lateral wall is squamous temporal bone. Floor is formed by dome of lateral semicircular canal. Trotman's triangle. A triangular area of the posterior fossa plate behind the antrum. A triangle behind the antrum, it belongs to posterior fossa plate, bounded by sigmoid sinus, superior petrosal sinus and bony labyrinth. Sigmoid sinus, superior petrosal sinus and bony labyrinth. Sigmoid sinus inferiorly, superior petrosal sinus superiorly and bony labyrinth anteriorly. Sigmoid sinus inferiorly, superior petrosal sinus superiorly and bony labyrinth anteriorly is a Trotman's triangle. Solid angle is solid bone medial to the antrum and angle formed by all the three semicircular canals. Medial to the antrum and angle formed by all the three semicircular canals. Medial to the antrum. Key points in mastoid exploration. Always use the largest and short burr. Largest and short burr. Do not dig a deep dark hole. Always remember to saucerize the margin to open the antrum as you are proceeding deeper. If lost on the way to antrum, go high and forward. Identify the middle fossa dural plate and posterior meatal wall and prevent the fenestration of lateral semicircular canal. Identify the middle fossa dural plate, posterior canal wall, prevent the fenestration of lateral semicircular canal. Horizontal semicircular canal you have to save. Best way to expose the middle fossa dural plate by drilling the cortex in the line of linea temporalis until blue bone color changes. Drilling the cortex in the line of linea temporalis until the bone color changes, which indicates the middle fossa is reached. indicate that middle fossa is reached. This is performed using large cutting burr. This is performed using large cutting burr. This plane of exposure is followed into antrum. Large cutting burr exposed followed into antrum. Now change to diamond burr. Change to diamond burr, or it may fracture the dural plate, creating a dural dehiscence. Reaching the dural plate is identified by change in the color of bone. Change in the color of bone and change in the sound of burr. Change in the sound of burr vibrating on it. Reaching the dural plate is identified by change in the color of bone and change in the sound of burr vibrating on it. Change in the sound of burr vibrating on it. Continuous irrigation is required with drilling to cool the burr, to keep the field clean and prevent the bone dust clogging the burr, which decreases the cutting ability. Insufficient sarcorization is the commonest reason for not identifying the structures. Insufficient sarcorization, commonest reason for not identifying the structures, and awkward exposure and injuring the vital structures like lateral semicircular canal and facial nerve. 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 Lateral semicircular canal and facial nerve.